And we want to thank everybody for joining today. It looks like we have maybe 8 sites, half a dozen to 8 sites. And I want to thank everybody for coming today. What we thought we would do is go through a very brief slide set to tell you our progress so far. And Dr. Cole and Dr. Dickerson will do most of that. And I think, and then we want to have a discussion, but I think it's okay with me if we have a discussion along the way. Is that how Bonnie and Jane want to do it?
Fine.
And so just pipe in. There's not so many of you on the call that you can't just interrupt and ask a question. Is that so I think we'll keep that format. And then for those of you who are going to CHA, we'll present another more detailed update there at the end of the month. So I'm going to hand it over to, if there's no questions from the people who are on line, I am going to hand it over to Dr. Bonnie Cole. James, if there's any technical difficulties, do you want him to just speak up or type in, or doesn't matter?
Type in to the prompt.
Okay. All right, I'm going to hand it over to Bonnie. Go ahead, Bonnie.
Well, thanks. And thank you all for joining us this Valentine's Day. Hopefully, you'll all fall in love with plugs just as we have. We can skip to the next slide. So just a few administrative things first. I want to let you know that the Memo of Understanding and invoices are being prepared by Seattle Children's right now. I think I got a near final draft this morning, and we'll be sending those out soon. Sorry for that delay.
Hey, Bonnie, can I interrupt? I just want to say to the Plugs members that, you know, when we pitched this idea, I think it was in November, wherever we were, for the Kansas City, I think it was, for the CHA meeting, I didn't realize that there were, it was just a great idea, but, you know, it turns out, like, I got to get it through legal and billing and all that stuff. So that's what the delay is about. But we decided to just proceed with Plugs, even though we couldn't get it billed and to get contracts, you know, done right away. But now we're actually pretty close, so we'll probably end up bringing that stuff to CHA or mailing it out that week, since I think we're mostly done and everybody. There's just 9 more sign-offs to do, but there's no more editing. So sorry about that. Okay, Bonnie.
We're almost there. Other news: the website has been updated and will continue to evolve. You need to register, but if you haven't done so, we can help, and let us know if you have things that you want posted on the website, and we will start adding those on as well.
And specifically, all the sites' contact information is now on the website in the password protected portion, so that you'll be able to access your other Plugs friends.
Yes, we'll be able to talk to one another without needing to go through us. Also, the CHA, as Mike said, will help us organize a future WebEx. So in the future, CHA will be a part of that, and there'll be an update in Houston in just a couple of weeks.
Yeah, I want to thank Monique for helping us organize that, because it's a lot easier. You know how to poll the members and stuff, CHA members, and we appreciate your help.
My pleasure.
And in other exciting news, we hired 1 FTE to help administer Plugs, so we're really going strong here. And that's all for the administrative updates right now.
Is administrate a word? I use the word administration.
I think so.
Okay.
Yes, I think
exciting.
So. It is. Oh, that's okay.
Administrate. All right, sorry about that. Go ahead.
All right.
All right, next slide.
So this is, we'll start just by going over the demographics, the needs assessment portion. So basically, I think that most of the sites are on there. I apologize if there are any errors, but overall we've done 9 assessments. So there are still a few of you out there that we haven't talked to. If you're out there and listening, just please contact us. These are to help you so we know what people want in the future. The labs ranged from about 800,000 to about 2.3 million billable tests per year, though for the pediatric hospitals, the adult ped centers up to about 6 million billables a year. Even though we didn't specifically ask for it, some people did mention that their send-out test bill or cost was between about $3 and $14 million per year in this. We have seen an increase in this ourselves over the years, as most people have. The range of lab staff, about 4 to 20 MD PhDs. Lab staff ranges from about 90 to 250 staff members. A few sites did have lab genetic counselors that others were hoping to hire, but most still did not have lab genetic counselors. And the range of send-out staff resources were between 1 and 6 dedicated FTE. And I think we'll now go to Jane, who will talk about our top 10 needs assessment findings.
Bonnie, can you go back? I had a question.
Sure, what's that?
This question for Mike with my colleagues here. So we have it looks like we have one participant from Canada.
And I apologize because I'm not really sure where Calgary Lab is.
Okay.
That's all right.
Somewhere there.
But they're not on, so we can tease them. You know, so it looks like the 51st state, Canada, is represented. So that's nice. That's an adult system. I think the one thing I would add, Bonnie, to what you said is, so people have found out about plugs primarily through the CHA. So if you look at the members, if you look at the participants, they're primarily from that initial CHA group that we talked to. But then I think we gave 1 or 2 webinars on utilization management, and that's how we gained, I think, our Canadian colleagues, and also how we gained Mayo Clinic. And maybe Hopkins too. Is Hopkins from the webinar?
Yeah, mine. Yeah.
Yeah. Okay. So so we have mostly CHA participants right now. We haven't done any active marketing. Just trying to keep it right now in a pilot mode, and so we make sure we're doing what people want. I think that's all I have to add. Jane?
Great, thank you. So, for those of you who participated in our needs assessments, and there were about 8 of you, you'll see some familiar quotes here, but I'm not going to go through all the questions that we asked, but instead we decided to rank it in a top 10 countdown based with 10 being the least frequent, although more than one, concern or excitement to be involved or anything along those lines, and 1 being the most frequent.
So this is a Letterman style?
This is a Letterman style countdown. So our first one here is 10. So we asked everyone if they were interested in an on-site consult or workshop after we got a little more established, and there were a few sites who did express interest in participating in this, as well as a few sites who have expertise and who would be willing to travel to help other sites as well. And again, this is the part where we'd like some feedback from you all as we're talking, so feel free to jump in, otherwise it'll go pretty quickly, which is also fine. And then there were a few sites. We asked everyone if they had resources or materials to contribute to plugs, and this would include established procedures or policies or algorithms, so anything related to either test-specific conditions or maybe more general policies and procedures and how you manage send-out questions and maybe DNA banking or any other kind of policy that could help reinforce a good background for utilization management when it comes to test orders. And so a few different sites already have existing resources and materials that they're able to contribute to plugs. And then you'll notice in the emails that we send out about every other week we post one of our own. Eventually we'll run out, so we'd like to
other people's as well.
Yeah. Feedback. And then there were even more groups who already are in the process of creating committees. And what was interesting is many of these are hospital-wide committees, so they're not limited to just the lab, but they involve lots of different specialties to help with utilization management with all testing, not just send-outs. And so these these will be really helpful, I think, as we start to share materials as these other hospitals are working on big actions within their own institution, and they could share what they learned with the rest of us. And then I wanted to put this number 1, but that's just bias from, I think, from our standpoint. So I removed it a little bit lower because hopefully not everyone has the same intensity of struggles.
Some of you seem to have
we do.
some good IT.
But I think it was we did ask about the lab's involvement and the lab's ability to handle IT situations. This is with test creation. So when you're defining new tests, or if you have CPOE, are you able to manage prompts and top-ups for helping guide utilization in that way? And I think it's the minority of people who have really strong involvement in this area, or at least control. So that'll be an issue that we can all commiserate and work together on resolving. And then about half of the people that we talked with have concerns about how utilization or the lack of can affect patient safety. And this is specifically driven, I think, to send out testing because it can be complicated in choosing the right test to order, and the genetic tests are frequently confusing for both the provider and for the send-out person to interpret the right test so the error can happen on both ways. There are long turnaround times associated with these tests, whether or not it's send-out or in-house, and that can be a concern for patient safety. And then these are complicated reports when we're talking about genetic tests, and manual result data entry is an error. So this is a big push, I think, for many places to proceed with better utilization to improve patient safety.
Yeah, I just wanted to add that another consideration in pediatrics is just the blood draw volumes, and especially in kids, this can cause a lot of potential harm in terms of kids having multiple tests over and over, and if they're and possibly needing transfusions in ICU settings.
And so for the next 5, so these are the ones that I think that everybody had some kind of impact, and so halfway through, I call it the melting pot, melting pot, because we're pretty split down the middle. There are about half of us that have 0 utilization management strategies in place and are really looking to start from scratch in that. And then there's another half of us that have pretty good structured utilization management strategies already in place, although we're all looking for ways to improve or to collaborate together. So that's kind of the interaction of the different sites that we'll be having. And one of the things that we heard over and over was the need and the desire to have standardized and national guidelines for these pediatric conditions in terms of how to manage test requests. So I think we can create a pretty good starting place for coming together and developing these policies as a group. And I think one of our interviews, we got a quote that said, there's really safety in numbers. So if we can come to a consensus among us, then it'll be easier for us to institute things in our own institution with the backing of this collaboration. And then I think it's difficult for everyone to manage the miscellaneous test requests. And this, I think, is culture dependent. So there are a lot of places where there's free reign among their providers and what they can order and how they can order it, which can create a lot of time on the people who actually manage the send-outs. And then I think there's an IT component here too, is how do you effectively manage miscellaneous tests and when do you build them, and there are different approaches among our different members for how they handle it. And I think one of our sites, I won't mention any names, said that anyone can order any test and have it sent anywhere. So this is a problem, and this is actually kind of the opposite mantra that you might hear, right test at the right time for the right patient, whatever that one is. So this is kind of just another take on that, and gone the other way. So we're certainly not alone. And then in another place, we heard that in our work cultures, our providers live by the mantra, if it's interesting, just order it. And so that leads to a lot of extra miscellaneous test requests in there, because it's not necessarily the clinical picture that's driving test ordering. And then every single group that we talk to wants more algorithms, and they want more guidelines on how to, or at least written guidelines on how to communicate with their providers on different tests, different conditions, and the best testing approach. So we heard that. And then I don't even think I need to say this one aloud, because it's certainly one of the main motivators for why we are all together and having this conversation, is we're getting to a point where we just can't afford it anymore. It's expensive for us, it's expensive for patients, and I guess there are a few people who are benefiting, but they're not. They are not pediatric institutions.
Skewed.
Okay, so that is kind of the overview of what we learned from everyone's groups in our 8 needs assessments. So thank you again for talking to us about that. And does anyone have anything to add or wanted to know something specific before we move on?
Comments?
Okay, so the one interesting thing about the genetic testing is also make up a good hunk of their send-out bill through billing and marking up the test, and other sites, because of a variety of rules and also because of their payer mix, are losing tremendous amounts of money. So there's variation there. We didn't find anybody who thought they were making money, a significant amount of money on genetic testing send-outs. I guess if they were, they wouldn't join Plugs. All right, so let's go to the next slide.
Before you move, this is Rob. Can I just make one quick comment?
Please. Yeah, we only have a couple more slides anyway, Rob, so go ahead.
Does anyone have a sense about what the new single molecular codes are doing to reimbursement? I've been looking for information on that, but I haven't found any yet.
I don't know, but we know who has.
Yeah, there's, you're reading the same things we are, Rob, about Palmetto and some other places and the methods they're using to determine reimbursement for the individual codes. There's one scheme that's based on median reimbursement, looking at a sampling of sites and how much they charge. But we don't know. We obviously have a small molecular lab, but it's got some reasonable volume in there, and we don't know yet its effect on us. Maybe some of the larger sites like CHOP or somebody who has more molecular testing, like Children's Mercy or somebody like that, might have more insight. We could put that out as a question on email to see if we can get an answer in the next email. Is that reasonable, Rob?
Oh, sure. And I think we're all probably reading the same publications, and we'll probably see it at about the same time.
Yeah. Okay.
It's a big issue, though.
Yeah.
One thing we noticed here in Minnesota is that we had an extract and hold code that we were using for some of the DNA testing while it went through prior authorization, but after they had seen the clinician, and then that extract and hold code isn't available anymore. It just has to be absorbed and not authorized.
Right. I heard that.
Thanks, Chris. Okay. Anything else? Okay. Now let's go to the next slide.
I love you, my love.
There's someone there's someone not muted, and we're getting to hear your personal conversation, so you might want to consider whether you want us to hear that. And you don't have to be muted, but if you're having a personal conversation, we all can hear it. Okay, so the last couple of slides before open discussion, and we can discuss it as we go, is trying to expand for participants their ability to start talking about talking about general questions as well as about general cases that are occurring or specific cases that are occurring in their institution. So we want to have office hours. Obviously, the ideal state would be that you could call, anytime into a phone number and get help with a specific case or with general questions related to utilization management, where you could get tips or just share your burdens, because the burden shared is divided, and you might even share your joys, because the joy shared is multiplied. And then we could disseminate what we learn from office hours to the group. So that would be the ideal state. Obviously, our current state is 0 office hours, so even if we had a couple hours a week, that would be a nice addition. But the idea is to eventually, to have a lot of members, especially CHA participants, and the pediatric component of adult health systems, and give a broad range of hours, because people, some people live in Hawaii and some people live in New York. So that's the overall idea, is that you call into a call center, or if you email in during those hours, you get a pretty quick response. So we started putting together ideas for this, and we certainly can do some of it from Seattle Children's with our own genetics counselors and doctoral level people. And we certainly could work with you, so that if you guys have a genetic counselor who can put in an hour or two, that we could do it through some kind of conference line. But Mayo Clinic I've worked with on a lot of projects over the years. Kurt Hansen, who was former chairman over there, and some Don Flott, a bunch of people who I've worked with over the years, said that they would be interested, because they have a national interest in utilization management, and are involved in national policy making, and they also have a reference lab business, and some of your clients. But they already have a call center, and so they've offered up a potential collaboration that we're talking to them to, we could route it through a Mayo call center number, and then have, and then have it go to whoever is manning the plugs call center, and they could contribute. They have genetic counselors to contribute, just like we do, and a couple of you do. So that might help us, because it's a big thing to operationalize. I think it's an important feature. They already have it, and also it involves some IT with regard to tracking the calls and all that. And in IT, we're certainly on the weaker side. So that's something we are in conversation with Mayo, and it looks, pretty good. And I think we should take advantage of that if we can. Next slide. So just to, so this is sort of how we're seeing it right now, based on the needs assessment, and also based on the kinds of things we would like, because we're probably pretty typical, and then in talking to you. So we think there's going to be 3 kinds of questions. One would be general questions. Example, do you guys have does anybody out there have a policy and procedure related to a specific test or an algorithm? How are you handling send-outs to Prometheus for celiac disease? How are you handling this or that genetic test? What is your general approach to prior authorization to protect patients financially? What are some of your strategies for implementing them in non-genetic in clinics that are not genetics? And there can be a million of these. And then tips. I have a provider who's a son of a gun, but a good doctor, and a hell of a golfer, but really a pain in the neck to deal with. What are some tips for communicating with that provider related to their ordering practices. How do I partner with medical directors to get the job done? Will you come down here and deal with this provider for me if I took you to dinner? That kind of thing. And then your questions or concerns or sharing feedback about UM strategies. So that's the general type of questions, and those are, relatively straightforward to have those kind of conversations. Then there's the next level would be advice about a case, that you have a specific case, and you're not going to share, this is the light version, you're not going to share PHI, but you're going to give the general aspects of the case and get some advice on how we or whoever is manning the call center, how the Plugs consortium would handle this case, and those would be potentially entered in a database so that we learn something, that we can eventually learn something from the cases and try to develop consensus guidelines, which the needs assessment shows people would really like. I would say there's two flavors of advice about a case. One for places that are not academic or don't have any academic interest at all, but just want advice on a case. They don't have to, and they're not going to appear on a paper or a grant or anything. Then I would say that they don't need to sign any kind of participation agreement. The memo of understanding that we'll send will cover them. But I know there's a bunch of, I've talked to Greg Buffone, and there's Christy Pacheco and others who want to, who are more interested, who are also interested in studying this, to, dive deeper, to get some real insight, to produce some guidelines with some real teeth in it, and, would like their data entered into essentially a database that encompasses their institution and many others. And we already have an IRB here, and we would just send a participation agreement from the Seattle Children's Research Institute so that you could join, and it's all, kosherized. So that's two flavors of that. It's just for academic places and for non-academic places. And then the third flavor is something that we're just exploring. It's on the table because I think one or two sites mentioned it, is the idea of, can you just take this case and deal with it and deal with this doctor? And I want to give you all the PHI, and I'm going to fill out a form that you send me that has tremendous amounts of detail, and you guys deal with this and practice medicine in our state. We want Plugs to practice medicine. Now, this is obviously a lot harder to set up, and this would be a pilot research at first, until we get an IRB and all that. But now, some sites said they don't want this at all. They want to handle all their own cases, but they want to be in with the group that provides advice and consensus and commiseration and tips and frequently asked questions and tools. And that's fine. But there are some sites that have said, look, I have nothing. I have nothing here. I have no pathologists who are interested. I don't have a genetic counselor in the lab. I have a terrible insurance mix, and we're getting killed. And I'll join this thing if you can just, take over some of these more horrible cases. So we're working on some help for those kind of people. It's certainly not a requirement for people to do that, but that's that's sort of the range of things that we're thinking about, from least intense, which I think we should get going right away, to most intense, which will take some real operational work. And is that it, Jane?
It is. I just go through the workflow. People want to know more specifically.
Yeah. So this is So this is workflow for a case that didn't involve, for number 2, that didn't involve PHI. CHOP or Minnesota Children's or whoever, Denver, Rob, Denver, you'd flag a request, and you'd contact us during office hours. We'd discuss it, and you get a Plugs consensus answer, which is, in this case, we would tell the doc, what we would do is we would tell the doc that we think they should do sequential testing for the top 2 mutations, covering 92% of the cases, and only move forward with the remaining mutations if there was a negative result and still a high index of suspicion. And that would, on average, save a certain amount of money. But it's your case. It's your docs, your case, you're practicing medicine. We're just saying, given this is what we think would be an approach to it. But you have all the details and the PHI and all that, and then you guys would participate. You would you would, and we track this stuff so that we're giving consistent answers each time in a standard call center fashion, so that, and as we accumulated de-identified information in the database, we'd share it with Plugs members. These are the kind of calls we're getting, these kind of answers we're giving, we're trying to give consistent answers, etc. So that would be that, and then the next flow is for the intense case, which will be a research pilot. I'm actually not going to go through this, but this is basically you flag the request, you send it into a group that practices medicine and says, this is how we rule. This is how we rule on this case. This would take some design, but I think this would be very useful for some of the members who really do not have pathologist or genetic counselor power and who are suffering tremendous financial loss and actually can't even offer, or we have sites who've talked to us, they haven't joined, but if we had this, they would, that can't even offer genetic testing because it's so expensive and the payer mix is so bad, it would basically shut the lab and it would just make it impossible for them to just have their core lab if they were spending $5,000 on some cardiac genetic test. All right, I think that's it, right, Jane?
Yep.
So what is the next slide? Is it a cute picture with kids?
Yep.
As in all children's hospitals, we like to end every presentation with a cute picture of kids. And so now I just open it up for discussion. That's what we're currently thinking about, and I would like your feedback on whether, especially on any of the things, but especially whether office hours do you think would be useful, how useful you would find that, and what you would like. Maybe we could start. Greg, do you have any opinions from Texas Children's?
Dr. Devaraj has just joined me. She's shaking her head. Yes. You want to say?
Saying that, yeah, I think that would be a really good idea.
I'll go around it.
So I think, if you have a website, maybe in the first 3 months to collect what you get as your most 10 top questions,
Yeah, and how we answer. And then the group can modify it, can then sharpen that pencil, put it through the crucible and come out with kind of a consensus. Is that what you're thinking? All right. How about Rob? And then at Texas Children's, and would you be most interested just in the non-PHI cases, or because you're a huge group, or would would it help you if some other group did your case management?
I don't see us going down that last road.
Mm-hmm.
Yeah. Yeah, I think, that makes sense for you guys. How about Christy Pacheco, are you there?
Yeah.
What's useful for you guys in terms of office hours? Or is it useful?
No, I think office hours would be useful. I guess the other thing that I think would be interesting about it is if we were all sort of doing it to collect the information and maybe to have that would help us make a standardized sort of like testing. It would help with the algorithms. I guess the hard part would be for the people that are already doing some utilization management is to recapture some of the stuff that's already been done, but maybe some of the people that are, just moving forward with getting utilization management could really help us with that as we kind of helped them with the other parts.
Could you give me an example? What do you mean?
Well, for instance, like here we have like tests that cost over $1,000 have to have pathologist approval, or we have some tests that we approve, for instance, the HLA testing for the for celiac disease. If they've had a biopsy and they have borderline enzymes, then we'll approve it. But I would never call in to figure out I would never call in to figure that out because that's already been figured out here. But it still needs to be part of the standardization for that disease.
Sure.
Yeah. Okay. Well, and I think that it sounds like it's a good idea to start collecting things that people who have policies and procedures start collecting which ones they're willing to contribute.
Yeah.
And if they haven't written them down, then we just need a way to capture them through interviewing you or whatever, right?
Yeah.
How about Rob? You know you're famous. You named plugs. I had a crummy name for it, and you came up with plugs. What would be useful for Denver Children's?
Well, first, you're very kind. It was just a wild thought that happened to pop into my mind, but I'm grateful to have contributed. As far as the models that you've presented, I don't think we would do the third one either with the PHI. I think we would do the second one. And just a comment about your collaboration with Mayo Clinic on their call center. I think that's a great idea. They have a great call center, and I know many of the people that you mentioned, and I think they'd be really good to work with. We're a Mayo client right now, but even if I wasn't, I think I would be in favor of that.
Okay. Who else do we have? My friends, John from CHOP. What's useful for you guys in terms of what I presented, or what we didn't even, or something we didn't present?
It's people, Mike. It's
hey, people.
Collaboration and non-PHI.
Yeah. Okay. Who else do we have?
I just wanted to jump in and say that for those who want kind of a lower level of involvement, it would be interesting to have sites that are kind of controls that don't. If you're not interested in participating in office hours, but you could still collect data on what your send-outs look like for certain tests, that could be very useful to compare between sites and show that utilization management is working when we're implementing certain strategies. That could be helpful.
Has there been any thought of like having like a listserv for the site?
Yeah, we've talked about it a bit.
Why don't we
to do the office hours? I don't know.
Pardon me?
Yeah, the listserv would work, I think, for general questions in terms of also polling to see what other people do. I think it would be harder to standardize in that case because, you know, you could get 5 different answers potentially. But it would also be a way to capture dialogue.
Yeah. I think that's a good idea, and then, you know, it doesn't have that much risk, right? Because you could just, the negative side of listservs is people eventually turn them off if they get too active. So I think that's one that's good to have in the bag, though.
Mm-hmm.
So why don't we do an experiment with that and set up an email listserv and see how that goes. I actually think it will generate more positive, and then people, like I said, can turn it off. Who else do we have that you want to call out?
Mike, it's people again. How about the hours? Since we have 3 hours time difference.
Well, you know, I'm up early, people. So, you know, I moved out here 22 years ago from Philadelphia, but I never switched time zones. So.
Yeah, I think that's a real big benefit if we move forward with the collaboration with Mayo.
Yeah, that was one of the advantages.
Yeah, they're open all the time.
Yeah, but we certainly would, no matter what we do, we would encompass times that are useful for, you know, East through West Coast. Yeah, that was one of the motivators with Mayo, was that we would have broader hours, and then you know, they have a slightly larger bank of genetic counselors who are willing to align policy-wise with the CHA group, and so that was one of the, you know, besides a bunch of technical advantages and the fact that we've had good experiences with their call center. You know, the reason I got involved with their call center was they actually helped me build a call center at UW years ago and trained us, and really worked out great for us in terms of improving customer service. So, you know, I happen to know the people there, and they're still there because no one ever leaves Mayo. So I guess it's too cold. So that's that. So what about, who else is there?
What about my friends from Nationwide? Is Amy Pyle there?
No, Amy is actually at the AACC meeting, so it's just
Beth. The MSACL. Okay. Hi, Beth.
Wherever she is. Yeah, I think we would definitely use the office hours for general questions, and then cases without PHI for sure. So I even think that we have on-site genetic counselors, but even if they had an overall question, I think it would be nice for them to maybe even have peers that they could call on this, through these office hours to obtain more information. So I think it'd be great.
Great. And what about our Stanford friends? Ann Fulkin?
Yep, I'm here. I think I would echo what everybody else has said, that I probably wouldn't do the PHI, but I would be interested in sort of asking, maybe not even case by case as they come up, but I could use the office hours to sort of chip away at issues that we have.
Right.
And
like,
I could sort
talking
of
about like classes of cases, like cases, like groups of cases that are similar that come up. Yeah, that's the kind of thing we were thinking about. Did we miss anybody? Who's on the call? Is Mayo on the call? No, I don't see anybody. Okay, so I think if we haven't gotten to you, maybe you can speak up. We tried to look at the people on the call, and then I think we'll ask these questions again at the CHA meeting, and then maybe try to put it in a smaller survey that could be filled out in just 30 seconds or a minute by email, because we don't want to overburden people. Are there any other issues or concerns, questions that people have, ideas for today?
Website access.
Problems?
Mike, this is Monique. If you're going to have me do the launching of the WebExes the next time you want to have a webcast, I hear a lot of names on the phone that I don't know, and I know on your website for the contacts you have pretty much everybody is the lab director in the children's hospitals, it looks like. Yeah. So, and I know you can forward me all of the everybody else's contact information, but I just wanted everyone on the phone to be familiar with my last name, so if it comes to your inbox, it's Trojack, and spelled Trojacek. And perhaps maybe the first time we send out the next webcast, you all could push an email out to all the members as well, saying expect to get this from Monique. So then then they'll recognize it.
Yeah, and we can add as many contact that people want on their site. So if you think someone's more appropriate or would like to be included, just email our team, James Britt and Barry Weisband, and they'll update that.
Yeah, so that's a question I have. This is Greg Buffone. I've got, several people in the CP faculty that I'd like to have access to the website. How do I arrange that?
All you need to do, Greg, is to either provide, if you're already a member or registered, provide them with the information you have relative to a password and a username. If that's personal and you'd rather not give that out, then re-register with a more generic username and password, and you'll be able to disseminate that amongst your team members.
Okay, I'll take the generic approach. What's the URL again, by the way?
It's schplugs.org.
Okay, thank you.
Thank you.
And then, Greg, we're going to try. There's a bunch of people who've contacted me, and I talked to you on the phone, Greg. I know Christy Pacheco, there's many, so I'm going to miss some, but Marilyn Hamilton at Children's Mercy, I see they couldn't make the call today, who are interested in, in sort of publishing some consensus data and all that. So I'll try to organize that, and if you have certain faculty members who are interested, just let them know that we are pretty open about academic collaboration. We're not looking to shut anybody out. And if anybody wants to dive deep in a particular area to make policy and see what the interventions do, we are very open to that.
Okay, I just had another thought. We're probably, many of us are working on lab utilization data and publishing, and as those publications come up or available, it'd probably be worthwhile to announce them through the website.
Yeah, we actually have a great place for that, so please share with us. And we've got, at the end of our newsletter every week, there's a place that will put relevant publications, and we can put them on the website too.
Yeah.
So, yeah,
And they can remind us. People shouldn't be afraid to remind.
Yeah. Feel free to, if you find something and we don't, just let us know and we'll share that.
Yeah, send it over to us and we'll post it on not only the website, but also send it out on our weekly plugs email that comes to you every Tuesday evening, maybe Wednesday morning.
Yeah. And if there's anybody who has, if you got anybody's developing webinar materials that, we can broadcast that through the webinar series. I mean, one of the reasons to do a webinar series is it integrates well with plugs, and utilization management topics are popular. All right. Other comments or questions?
Well, I must be technically challenged because I filled out I've done the interview and I filled out the paperwork, and I think we've even sent you a check or tried to send you a check. But I can't get past the login sign up. It just wants me to fill out another form.
We'll do, is this Greg?
Yeah.
Greg, if you don't mind, James and I will work with you offline to make sure that it runs smoothly for you. I'm not
sure, I don't take up everybody's time with that.
Right, no, but we'll make sure today that it all works out for you, and we appreciate your patience on that. We're not sure exactly why that's happening right now.
Is anyone else having problems like that? That's tried it?
As I said, I'm probably just a technically challenged one.
This is Ian from CHOP. Will the slides from today be made available anywhere?
Yeah,
yes.
Yeah, we'll put them on the website too.
We are recording this, and it'll be posted to SCH Plugs website, or our Plugs website, and it'll be available to all of you and
to the people who couldn't attend.
And to any of the members and to all future members. And if you know of a colleague who's interested in plugs, please feel free to share their contact information if that's appropriate.
All righty, thanks.
Great. Thank you all.
Anything else? And thanks, Monique, for organizing the next one. We'll see everyone down in Houston.
Sounds great.
All right.
Good.
Happy Valentine's Day.
Happy Valentine's.
Bye-bye all.
Bye.
Thanks.
Thanks.